Just to say, it's an absolute pleasure to introduce Professor McLean, who's going to talk to us about pregnancy, the heart, and the use of echo to image these patients. Professor McLean probably needs no introduction at all. He's one of the godfathers of bringing critical care echo to Australasia and the world. Extremely happy to have him on today. Prof is also a cardiologist, as probably most of you are also aware, and one of his interests is in pregnancy and the use of echo. It's a great privilege to have you here, Prof. Thank you very much for your talk.
Thank you, Sam, for the introduction. The talk's about pregnancy, the heart, and echo. And for those of you who have an interest in obstetrics, believe you me, a combination of intensive care and obstetrics is a great combination. The way I'm going to approach the talk today is to look at it in two ways. One is the antenatal assessment. This is probably less intensive care oriented unless you are involved with these patients, because we really usually get involved from the pure intensive care viewpoint when there's a perinatal acute assessment, some peripartum problem that comes to our attention. But I'll just run through a bit of the background of antenatal assessment, because it's really important to know what population you are dealing with. There are specific cardiac pathologies in the pregnant woman that come up from time to time. There's congenital there. I'm not going to go through them, talk about the list, you know the list. There's hereditary ones, and I've put them bicuspid aortic valve there because that is one that you will come across from time to time and does have a certain relevance to, as you'll see in the talk today. The other areas are rheumatic, probably more important in some parts of the country than others. And my experience is that valvular disorders are mainly associated with people who've immigrated from countries that have had a higher incidence of rheumatic fever than we have here, or we're from indigenous populations where it's more prevalent as well. Cardiomyopathies is the one people usually associate with pregnancy. They can be pre-existing or de novo, and sometimes you can't tell the difference. And coronary artery disease is not common, but it does come in from time to time. A lot of the women now having babies are in their 30s, and some of these women do have underlying coronary artery disease. So it does occur, not often, but you've got to keep an open mind. The most common cardiac pathology that I would be asked to see a woman who's pregnant, and the obstetricians are worried about the delivery, etc., is arrhythmias. And the arrhythmias are really, you've got to decide whether it's non-ischemic or ischemic. Are there other pathologies causing it? The most common type is SVT, and that's really dealt with symptomatically. Atrial fibrillation is a little more troublesome because you either have to get it out of them or consider anticoagulation in a pregnant woman, which you don't really want to do. Ventricular ectopy is probably known more or less common in the rest of the population, and a number of them are ill-defined. People who come with palpitations, it sounds like arrhythmias, but you can't pick them up. But these will be the most common cardiac pathologies that you get asked to see with pregnant women. Now, this is an old slide, and the percentages, I think, have changed over the last 20 years. This is 1995. But I put it in to show that there are some defects, congenital defects, or other cardiac defects, which are a lot more dangerous than others. For example, if you're in group 3, if you've got pulmonary hypertension, coarctation, or Marfan's with documented aortic involvement, you are at very high risk mortality. And this is the sort of woman who, if was considering becoming pregnant, you might suggest that the risks outweigh the benefits. The second group is, we see a number of those. For example, previous MI is not around, it comes up from time to time. Somebody with Marfan's but a normal aorta, mitral stenosis with AF, etc. So you can see a number of them come into play. And group 1, yes, they are abnormalities that you identify, but the mortality is very low. And of course, the reason these figures have changed is that if you look at some of these repairs like the corrected tetralogy of Fallot, or porcine valve, this was in 1995. So these were women who had this operation done, say, 20 years earlier, 25 years earlier, say in 1970, whereas the operative techniques have changed dramatically as well. So the 20-year-old woman you see in 2020 with these conditions should have even a lower mortality risk. So in everyday practice with these patients, well, congenital heart disease is uncommon, but you know about them. There's very few women that have congenital heart disease and have forgotten they've had an operation or 2 operations. Ischemic heart disease, normally known about in advance. They don't normally present de novo in the middle of pregnancy. Valvular disease is commonly encountered, and arrhythmias, as I said, is common, mostly benign, but don't overlook the fact they can be quite troublesome. Now, in Australia, what is your risk of dying? And what is that risk of dying from a cardiac cause? Well, this is just 2017, which are the latest figures that are available, collected figures in the Australian Institute of Health and Welfare. And you can see that there's 16 maternal deaths, complete overall, which is about 300,000 deaths, or 16 maternal deaths per 100,000 women giving birth. But you'll notice, in fact, if you look at the right side of the slide, that most of these deaths come from a cardiovascular cause. And so that's very pertinent to intensivists who are doing echocardiography. I mean, there are some sad signs there, suicide being 4 out of the 16, which always strikes me as a particularly sad number amongst the others. Has it changed over the years? Not that much, really. They're around about deaths per 100,000 are hovering around about 6. You can there's a certain classification which you don't really have to get too worried about. Is the mortality directly from the pregnancy? Does a woman bleed to death at the time of delivery, or does she have another condition which is exacerbated by pregnancy and she dies from that, so that would be indirect. So, but overall, the numbers are important, 6 per 100,000 women. So in an institution like ours at Nepean, we have about 5,000 deliveries per annum here, with on the precinct, which is the private and public combined, which means that we would expect on this average about 1 woman every 3 years will die, which doesn't seem like a lot, but when it happens, believe you me, it is an absolute tragedy. Just another way of looking at it, the number of maternal deaths over 20 years, over 10 years, once again, it's cardiovascular which have the most. But if you look down the list, you'll see another pathology that's of great interest to us, and that's thromboembolism. And when you have about 20 or 19 for that, plus 26 for cardiovascular, it means that 46 of those deaths are primarily cardiovascular in origin, and they're the ones that we are particularly interested in. When do they die? Well, as you can see, most of them die around the day of birth. The spread before and after, particularly during pregnancy, early pregnancy, it's more indirect death. It's the underlying condition compounded by pregnancy that's more likely to kill you in trimester 2 and 3, although the pregnancy itself may contribute in the first trimester. But please notice that your risk of dying doesn't really drop dramatically after you've delivered. And that's what we often say, and this is just not cardiovascular, but women with preeclampsia, for example, don't assume just because the baby's delivered, you've given them a bit of magnesium, they're looking good, everything's okay. Mortality in the first 2 weeks following delivery is still really quite considerable. And as you can see, over that 10-year period, there were 40 deaths in women who died in the 14 days post-delivery. So let's get on to some cases. And I've just chosen a few cases to give you a little idea of what you can deal with these patients when you're doing echo. This is a lady, a 21-year-old, that came down from Parkes, which is a town in Western New South Wales. She was pregnant at 33 weeks. She had lost a number of pregnancies in the past, and as far as one could read, with what was written and what was not written, domestic violence played a part there. But the interesting thing, I guess, from the purpose of this presentation is that she had a history of congenital aortic stenosis. And the aortic stenosis was a subaortic membrane, and more than the direct valvular stenosis. And she'd undergone 3 sternotomies, 2001, 2004, 2014, and this was last year. So it was 5 years since her last sternotomy, when she'd had that subaortic membrane resected once again and had some muscle taken out of the left ventricle. When she turned up here, she stated she had aortic stenosis. She was somewhat vague, she was unwell, she had mild nausea, and a TTE was performed. Now this is the picture, and you'll notice this is a transthoracic, and if you look at the left upper picture, you see, look, that aortic valve seems to be opening pretty well. If you measure the aortic root, it's not grossly dilated at all. If you look at the next one to the right, top right, you'll see there's a bit of aortic regurgitation. The left ventricle seems to be pretty good. And there's the M-mode color to suggest that aortic regurgitation is probably heading into the moderate territory rather than just mild. But when you put a Doppler, a continuous wave Doppler across the LVOT, you can see you're getting peak velocities up to 3.5. I think we measured it on the next. Here it is measured here, and it comes in at 3.4, 3.37. So this disturbed the obstetricians, and so far she's said to have aortic stenosis. She's got Doppler evidence that would support that. As shown in the right-hand column, she's got a normal ejection fraction of 50%, I think it is. And when we do a pulse Doppler just below the valve, you can see that she's got a gradient there around about 2.6 peak gradient. So this is really quite important. This is quite troublesome because the question is, if this lady has aortic stenosis, this really has ramifications for her delivery. On the other hand, if she has a subaortic stenosis, and this would appear to suggest that she still has that, that also has ramifications because both are fixed obstructions. So if you get into trouble with someone who's got a peak velocity of 3.5 meters, when she's not delivering, then she could really get into trouble. And it's really important from the delivery perspective. For example, there's a lot of discussion with these patients. Do you do a spinal, epidural, general? As you know, with aortic stenosis, you don't want to do a spinal. Fluid management becomes very important because, yes, she may bleed, but if you give a lot of fluid and she can't get that fluid through the valve, you're in trouble. Do we turn around and do a vaginal or cesarean? And this is the question that's always asked. The belief that a cesarean is always the best way to go, I just should warn you now that that is not always the answer. But of course, this is the way it has to go. So what do we do? 2 days later, we did it. Oh no, this is not a toe. We did this is another view. And I don't know whether you're comfortable with this view, but you'll see that that's the aortic arch. And so what we did is we went back and looked at the aortic arch. And when we look at the aortic arch, and then we look at the flow of blood through the aortic arch, you'll notice those bottom two, which are essentially the same. You've still got a peak gradient of 3 or more. So that means it can't be obstruction, because if it was obstruction, the peak gradient would be across the site of obstruction, whereas this shows that the obstruction, the high velocity, in fact ranges from the left ventricular outflow tract through the aortic valve as far as we can measure around the aortic arch. So what we're dealing with here is not aortic stenosis. We are dealing with a very high velocity of blood through the valve and the aortic arch. And if we looked at it another way to say, well, look, you know, we're intensivists. If we really want to know how this woman's going to cope, we really want to know, can she put out a good cardiac output? And if we measured that, you can see that, in fact, she's got a cardiac output of nearly 7 liters per minute, whereas the cardiac index is 4.1. So she's got plenty of reserve. So the result of that is she has no significant aortic stenosis, and she doesn't have a recurrence of the subaortic membrane. She's got a high cardiac output secondary to two things. She's got moderate to severe aortic regurgitation, and she's got pregnancy. So what we're measuring is a high velocity, which we, out of habit, report as a stenosis, but in her case, of course, it's not. And that just brings us back to a few physiological basics. Your plasma volume reaches 40% this is in pregnancy, above baseline at 24 weeks. Your cardiac output increases up to 50%, particularly in the early pregnancy, particularly due to the increase in stroke volume. In later pregnancy, increase in heart rate. Your heart rate starts to rise about 20 weeks. It keeps rising until about 32, and it remains relatively high for the woman. It might not be high for you or me, but for that particular woman, it remains high for a few days postpartum. The blood pressure, the systolic normally drops early in pregnancy. The diastolic drops in the second trimester, and this is all due to active vasodilatation. And your heart size can increase by up to 30%, mainly because of the increased blood volume. So this woman, in fact, is okay. She's got to handle pregnancy okay. She hasn't got aortic stenosis. She hasn't got a subaortic membrane. I've just put this in though to point out that in this day and age, these patients just don't go to delivery. You have a multidisciplinary meeting. This was in June last year when she was, when we sent her back home for a while. She came back at 38 weeks. And by then we'd actually have a plan all the way through from all the team members to say, if there's a problem, this is how we're going to deal with it. But of course, we were fairly certain, well, I was fairly certain, the others weren't so confident that she would get through the delivery well. Here's another case. Here's a 25-weeker, 25 years of age, transferred from the Midwest with query pneumonia, comes into our ICU, marked dyspnea. The only thing to note is he's had a history of antiphospholipid syndrome. Her first pregnancy, second pregnancy, I think she lost the first one. This is the chest X-ray she comes with from the other hospital. And you can see why they mention pneumonia, but if you look more closely, it really has features highly suggestive of pulmonary edema. And on this basis, we decided we would pursue the cardiac function as a primary investigation. And this is what we've got. This is her apical four chamber up on the left top corner. The left atrium looks big. The ventricle is reasonable, but I don't have to point out to you, since we actually accentuated in that second image on the right, you can see that her mitral valve doesn't look particularly normal. And she's got sort of almost clubbing of the anterior and the posterior mitral leaflet. And in fact, if you look, it probably doesn't demonstrate it that well, but if you look at the bottom left-hand corner, you'll see that in fact, she's got mitral regurgitation. And if you were serious enough to chase it all the way through, we're getting into the severe category with it going into the pulmonary veins. When we try and estimate how well that valve is opening, you think it's opening reasonably well. And, you know, I wouldn't call it severe, but if we look at the mean gradient across the valve, it's 9.83. Then if you use that particular measurement of mitral stenosis, it's moderate. So she's got at least mixed moderate mitral valve disease. Here's another picture here. This is looking just once again chasing a little further. Now she's 25 weeks. We are now becoming a little bit convinced that her problem is not pneumonia, but we're dealing with a mitral valve problem. Pressure half time there, I think, is 68 milliseconds, which means if you're measuring mitral valve area by that method, it's 3.2. It's not a method we use commonly nowadays, but it's a little bit of supporting evidence. And trying to hone in on the valve a little more, it almost looks like vegetations on the valve, which are causing the valve dysfunction. Just to let us know, we would, I don't know about your units, but we would automatically like to have a lung ultrasound at the same time. And this confirms our clinical impression now that we're dealing with a lady who's got pulmonary edema and her respiratory function is not pneumonia at all. We're dealing with mitral valve disease. 2 days after that, we did a TOE because we needed to know, because this gets into rather tricky territory. Here's a lady with mixed moderate mitral valve disease. She's 25 weeks. Is it getting better? Is it getting worse? And should she have something done to that valve surgically now? Or do you think as a physician and as a group looking after her, you can get her through the pregnancy and then allow her to have the surgery when it's far less dangerous to her and the baby. On the other hand, if you get it wrong and she decompensates at 31 weeks, then you're in really big trouble, because everybody will turn around and say, well, there was the proof, you should have done something earlier. But just look at that mitral valve on the left-hand side. That's pretty unusual for a vegetation, but there's something else, there's something odd going on there. It's certainly abnormal. So let's talk about valvular lesions. Infective endocarditis, the one that we see most commonly, but the other ones are the Morantic endocarditis. You get mainly with neoplasia. Sometimes Liebman-Sachs gets pushed into the Morantic group. It doesn't really matter, but Liebman-Sachs was endocarditis occurs in SLE. And you may not be aware of this, but it's far more commonly found in patients with antiphospholipid syndrome than it is with SLE. And this woman's got antiphospholipid syndrome. Lambrel's excrescence, as you know, those thread-like tissues that you see, filaments that you see, and the others are tumors such as other tumors, masses, and thrombi. This is a Liebman-Sachs endocarditis, and I put this up for a particular reason. This woman has to have Liebman-Sachs endocarditis. She's not infected. She's grown no bugs. And the vegetations are classical. If it's infective endocarditis, then the surgeon will often go in and try and get rid of the vegetation and preserve the valve. The trouble with Liebman-Sachs endocarditis is that the vegetation is like a greasy wart-like structure that digs right into the leaflet. So you do not do a valve repair on this woman. You have to do a valve replacement, which obviously ups the ante if you're going to operate on her. And just have it stick in your mind, there's Dr. Liebman and Dr. Sachs. So if you want something named after yourself, you better get on with it. So just remind ourselves, you can have normal valve, don't have to have a new murmur, smooth or warty, more on the left side, mitral valve more than the AV, and this is not a Morantic but Liebman-Sachs, and they have a high embolic risk. I should just, before I leave this woman, we decided we would try and treat her medically and get her through the pregnancy. Now, you remember if I showed you the graph from some years ago, she would be in the second group of people with a risk of mortality. As it so happened, at 27 weeks, which was a week after all this was done, she delivered spontaneously, and the baby was looked after in the neonatal unit, and she went back home to the Midwest with her baby, and 6 months later was being referred for surgery. And I should say that's something we would try and do in this day and age, is to get them through the surgery, through the pregnancy, and let the surgery done when there's no risk to the child and the woman's in the best of condition, if you can possibly do it. However, for you as intensivists, these are more, they've been more elective type, or how would you say, prepared ones. We are often caught with the acute assessment. And I just want to give you one case study here, which warms my heart. It's a 17-year-old, urgent admission for post-cesarean section from the OT. This woman is 39 weeks pregnant, first pregnancy. She's previously asymptomatic. She comes into the hospital here. She's been very dyspneic and tachycardic for the previous 24 hours. And I remember her well because they asked me to go and see her on the day that she arrived. And I was in the unit and I didn't get to see her till the afternoon. I didn't see her because, in fact, they did a scan of the fetus, and the fetus was going into great distress and she was becoming hypoxic. So the decision was made to rush her off to theatre ASAP. So she went directly to theatre. That was the afternoon. She was taken there, I think, about 3 or 4 o'clock. probably about 4, I think. The anaesthetist, I think, probably lost a few years of their life that day because she was so hypoxic, they decided that they would intubate her. When they intubated, she became very hypotensive, so they gave her fluid. She had very low saturations, and she then pumped out pink frothy sputum out of the T-tube. They decided, the obstetrician, that the best thing they could do was get the baby delivered as quickly as possible, so they did a pretty rapid cesarean. And the anaesthetist felt the best thing they could do, because they were just absolutely stuck. They couldn't ventilate her. They couldn't get the blood pressure up. Is they thought the best thing they could do was transfer to ICU, ring up St. Vincent's Hospital, and they told us to transfer over to St. Vincent's Hospital ASAP, because this woman obviously has a pericardium cardiomyopathy, and we have to save her life. And I remember being wheeled through the door of ICU. It was 6 o'clock at night. We got the echo machine, and this is what she had. So with the first view, and within 15 seconds, we knew exactly what we were dealing with. And I'm sure you're all you're happy with the diagnosis? Anybody like to comment?
Anyone have a go? Nice one, Ravi. Just unmute yourself, Ravi. Go for it.
It's a parasternal long axis view, which shows restricted opening of the mitral valve. So it looks like, mitral stenosis with a dilated left atrium.
Give us a bit more about the restricted opening. Just describe it a bit further for us.
So that I can see very small, but it looks like a hockey stick appearance of the anterior mitral leaflet.
Fair enough.
And, yeah,
Yes.
that's what I can see.
The second we looked at this, we had the answer from all this running around. We had the answer within 20 seconds. She's got mitral stenosis. And in fact, if you look, it's not only stenosis, she's got a degree. There's just a color showing that she's certainly got a degree of mitral regurgitation, probably at least moderate, although that was just one view. Obviously, we had other views. There's the classical M-mode picture, which was used many years ago before there was 2D, and you can see the parallel shape of the anterior and the posterior mitral leaflet, classical mitral stenosis. And when we looked at the apical floor chamber, she has a huge left atrium. And the important thing there to notice is not just the left atrium. Look at the right side, because this becomes important. She actually has reasonable sized left right ventricle, and it seems to be contracting well, and the right atrium is not too dilated.
Is it unusual that this lady got to that stage of her pregnancy and was not complaining of shortness of breath, or was she just, did we just have an inadequate history? It's just unusual that this should be as, isn't it unusual that this is a surprise to someone? Because surely we should pick this stuff up, shouldn't we?
Because everyone's short of breath late in pregnancy. Everyone's short of breath late in pregnancy.
That's the problem. This woman obviously
it's the
was
pregnant
breathless.
women's fault. Yeah. When in doubt, blame it on the
But
patient.
they become bigger and they become more, and this is the art of echocardiography or sorting these patients out, is sorting out, a woman when she's 38 weeks pregnant, you would know. They get out of bed at night too often, they waddle around, they're tired of the pregnancy, they want the baby to be born, they're breathless. And so what's excessive breathlessness as opposed to regular breathlessness in your first pregnancy, you wouldn't have a clue. But I agree with you. They have that degree of mitral stenosis when she's not pregnant and not pick it up. So, and there's her LV, pretty good. There's the LA dilated, ejection fraction, pretty good, and pulmonary artery pressure 40. So, what would you, she's in your ICU, everybody wants to run, they love who's from St. Vincent's there?
We've got Emma online somewhere.
Everybody wants to send them to St. Vincent's.
Where is
Anyway.
she? Yeah, she is. Yeah. We're sending her your way, or RPA for Marte. We can do both.
So what do you do with this woman? She's got pulmonary edema, pink frothy sputum, she's hypotensive, and she's got a heart rate. It's not that fast, actually. I think in this one, it's only about 40 on.
You just got to diurese her, right? I mean, you just got to diurese the heck out of her, trying to settle her down, and if you can, get her to a stage where we can get her off the ventilator. So isn't it just diuresis?
Yep. Not quite not only diuresis. What's the other problem with these patients with hemodynamic function?
Heart function is fine.
Yeah. And will it remain fine?
No. So if you leave her like this, if you don't aggressively diurese her, it will struggle.
Yeah. You diurese, and what's the other thing you cover?
Don't know.
If you work in a country where you see a lot of these patients, the other thing which causes decompensation is atrial fibrillation.
Yeah.
Because as soon as you get atrial fibrillation, you lose the ability to get blood through that stenosis mitral valve.
And that's where you said the mortality you said mitral stenosis and atrial fibrillation, like the mortality of 20% in one of your first slides. Yeah.
So what we did there was this lady was quite correct. I looked at her and said, what we're going to do is we're going to diurese her like hell. And we diuresed her, and we put on digoxin to try and stop going to atrial fibrillation. And this woman, who was at death's door late that afternoon, the next morning was sitting up, extubated, holding her baby with her mother nearby. And I saw her for a few months afterwards and sent her for a valve repair at about 6 months. So the beauty of the echo is to cut through all the hype to know exactly what you're dealing with. And in this case, it wasn't anything fancy. It's like Sam says, diuresis, diuresis, diuresis. Another case. This is a 26-year-old. She's going to have she had an elective spinal. I remember this one very well. It's quite an old one, but some things stick in your mind. G1P1 became disconnect through the procedure. But what was more importantly, it was a perfectly good cesarean section until they were pulling the baby out. And then everything fell apart. She lost her blood pressure. She lost her saturation. She was basically in cardiac arrest. Anybody want to guess?
We've got Lewis or Seb. Who's doing that? Who's doing that DDU? We're going to hammer you. Danielle, do you want to take that one?
Previously undiagnosed pulmonary hypertension.
Yes.
I'm guessing, but why would that mean suddenly when she's being delivered that she suddenly goes off? She had pulmonary hypertension, surely it would be just...
So switch off in the back. I was cleaning it. So.
I think that they can decompensate around the time of delivery, can't they? Because of fluid shifts related to the delivery itself. And also, is there something to do with, like, if they give the syncosinone and stuff and the vasoconstriction related to that? I'm not sure. Grasping at straws.
Auto transfuse in a way once they get your own contraction. Take the fetus to the uterus, contract.
Say that one more time. We missed that.
Don't you effectively, once you take the fetus out, don't you basically auto transfuse them because the uterus contracts down, he's going to hold a flush of unclamped, in effect, the inferior or the
Saying, I guess, doing auto transfusion with the taking out the baby and get a massive rush of blood to the circulation that was previously obstructed.
Good. Now, first of all, what parameter do you look at? Because you're going to make your mind up in seconds in this case. You're called, you're going to make your mind up in seconds. You don't get bigger emergencies than this. You look for the ECG. Have you got a rhythm with no output, or have you lost a rhythm and that's why you haven't got an output? And that's a very important sign, because if you've got a rhythm, then you've obviously got the problem is likely to be something else. And the second step, if you've got a rhythm, embolus. And your embolus, it's either acute pulmonary embolus, or in this case, it's amniotic fluid embolus. And this is the picture of the amniotic fluid embolus, which shows that in fact within seconds or minutes by the time we were still CPRing this woman, in the middle of the night, we were trying to CPR her. Remember, it was early hours of the morning. You can see even with this long term.
It's so good. You can call it.
Sorry. And so you've got even this first view. Remember, this is being done during CPR, and that's the beauty of echo. You've got to do it. Get someone to do it while you're CPRing. And this would be unusual to get this view because it's parasternal, but you can see you've got a problem there with the right ventricle. And this is probably even more expressive. There's the right side of the heart. You've got to remember with a pulmonary emboli, whether it's amniotic fluid embolus, whether it's blood, thrombus, you can dilate up your right-sided chambers within minutes. Unlike the left side, you can't. And what you've got here, of course, is you've got a really dilated right ventricle, a really dilated right atrium. The supposition is, whether correct or not, that we're seeing those little bubbles that are coming through, those little masses, is that the amniotic fluid embolus. And the most important thing is why she's got no blood pressure is because that left ventricle is being squashed out of existence, and that left atrium is not even filling with blood. This woman had an amniotic fluid embolus, and to cut a long story short, there's just no way we could resuscitate her.
Prof, how do you differentiate between an amniotic fluid embolus and a pulmonary embolus? Just tell me how you think.
No, you can't really.
You can't.
I guess the other thing is that you've got an embolus. In this setting, you'd be highly suspicious it was the timing, it was the baby being pulled out, and does it happen at that time? But you couldn't rule out an acute pulmonary embolus, and that's where you as an intensive are faced with that, always that very difficult question, do I thrombolize as well in a woman who's just had a cesarean section? And do I run the risk of breaking up a thrombus that perhaps isn't there, but she bleeds to death from the cesarean section wound? And you know, that's the sort of world we have to deal with.
Sure.
Sometimes the easiest part is to do nothing because you don't want to do any harm, but then you won't save anybody either. So the other thing I wanted to say about the pulmonary embolus, what was it? Can't remember. Ran through my mind. Okay.
Do you find that in cardiac arrest in general?
The air embolus from an exterior.
Nice.
So I just, air embolus, one question. The other question is?
In cardiac arrest, do you find that the right ventricle dilates a bit, maybe if the compressions aren't optimized or something like that, the right ventricle?
Not unless you've got significant resistance to flow in the pulmonary circulation. This is an embolic picture of some sort or another. You can dilate up your right side from left heart failure, but I've never seen it as dramatic as this sort of thing where it just blows up before your very eyes. Air embolus, yes, well, air embolus is always one to consider. I haven't got it in here because he was a 60-year-old man who wasn't pregnant, but you can actually see an air embolus because you have a right side of heart filled with bubbles. And the good thing about an air embolus and doing an echo is that if you can see those bubbles clear in the circulation, you've got a good chance of pulling that person through. Okay, so an air embolus is like a sudden thing, it comes at a time, but if you hold them, you should be able to pull them through it. The trouble with amniotic fluid embolus is that you just can't. That's the other point I wanted to make. It is believed by many of us that in fact you actually get small amniotic fluid emboli from time to time, and that patient who is delivering a baby decompensates not enough to do CPR or anything, but then gets better. And then when you go to look for a cause, there doesn't appear to be a cardiac cause or a fluid problem or the anesthetic or the epidural. And it's hard to prove, but I belong to the group of people who feel that you probably do have partial amniotic fluid emboli from time to time. This is not my case, this is your case, Sam, but I put it in anyway.
Oh, God, but they're okay.
And it's actually makes a very important point, which is 31-year-old post-cesarean section, delivery twins, on the way to recovery, shortness of breath, collapses, saturations okay, blood pressure drops, given a lot of fluid, has a history of preeclampsia, a recent flu-like illness, heart rate 120 to 140, and you do an echo. Anybody troubled?
I remember this case. Who else have we got doing the DDU? Arnie, you happy to crack this one?
And don't make it up, just tell me what you see.
Well, Arnie, you're still on mute, buddy.
Sorry, no, I'm on the line.
Yeah.
So there's an apical four-chamber view. There seems to be hypodynamic function with small biventricular size, suggesting hypovolemia. I also see some air bubbles on the right, suggesting that someone is already fluid resuscitating. Of course, I would want to see more views, but I would be very worried about postpartum hemorrhage in this lady.
Yeah, no, I think I said the same thing, yeah.
Now, as intensivists, don't look at the video, tell me what else is going on.
So she's quite tachycardic.
She's very tachycardic.
And the other thought would be, don't clearly see P waves there. So it might be worthwhile getting an ECG, whether there's a rhythm abnormality, as you initially talked about. That could be a common, or it could be a confounder.
Click on
There you go. There's your ECG.
Yeah, nice one.
that.
I think.
The message, there's the lady later with the normal ECG. The message is that the take-home message is sometimes in these patients doing an echo is just as important to find that it's not all these other things that people imagine or you're imagining. It's something a lot more straightforward, and doing the echo can take your mind off dealing with a possible pericardium cardiomyopathy, whatever, because in fact this woman had an SVT. The best way to treat it was adenosine, and then she's fine. So a normal echo, you're quite right, I only gave you one view, that was a little unfair, but it's a normal echo is just as important in assessing the acutely deteriorating patient, obstetrical patient is finding an abnormal one.
What I quite like about this photograph, she was very kind when I saw the mum up in the ward afterwards. She gave me this picture of her. But I quite like that her newborn baby had the same heart rate as she does above her head, because that her mum had when she had the emergency. I thought that was very good.
All right. What's this one? 34-year-old, 35 weeks. Increasing shortness of breath, comes into the emergency department, and as you can see, she's pretty compromised. She's got a heart rate of 125, saturations of 88%, PaO2 of 58, PCO2 24, and systolic blood pressure 104, which is low for her. But anyway, so we're called down to ED to do an echo. They're worried about this one. That's a chest X-ray. I don't know whether you want to comment. Well, there's nothing to comment about. It's an expiratory film which makes the cardiac silhouette a little bigger than normal, but if you look at the lung fields, there's probably not too much to write home about. This is her echo. I don't know if anyone wants to comment. Maybe I'll stop one. They're doing well on here. Maybe I'll stop this for a moment. Might not compete up there. Is that can you see it contracting? Sorry, is that what?
Yeah, this is what they're saying.
Ah.
So I might have messed it up. I think I put smaller ones in there in a previous talk to try and show exactly if it's non-echo people.
Let me just tell you, the top left-hand one is the short parasternal, obviously. But I guess since we can't show you that, we should look at the one next door to it, which is this one. You can see the D-shaped septum, a very large right ventricle. This is confirmed on the apical fourth chamber, where you have very big chambers on the right side, and a pulmonary artery pressure, I guess somewhere around about 70 to 80 millimeters of mercury. If you've got a maximum gradient of 55, you're probably going to add on another 20 or so. So I don't think you'd have too much trouble figuring the diagnosis with a cardiac finding like this, which is appears to be an acute episode in a woman who's 5 weeks pregnant. Anybody want to have a go?
Lewis, you there? You happy to have a crack?
So the right ventricle appears not to be working. The pulmonary pressure there's only 55, and it's a sudden deterioration.
Yep.
So pulmonary embolus is a strong possibility, probably the highest initial one. I can't really make out anything else from the echoes apart from just the D-shaped septum, the end of diastole there. So pulmonary embolus I'm going to go with as the first option.
So what would you do with it? They want you to take it off out of the ED in the next 2 seconds. It's all a little bit too much for them. You've got to take it. You're going to look after her. What are you going to do?
You said 31 weeks pregnant?
I think it was, let me go back. Forget that. 35.
Was it 35?
35.
Yeah.
Yeah, it's her first pregnancy, by the way. So she's terrified.
Yeah. So I mean, thrombolysis is clearly something to start talking about. And you'd want the obstetricians very closely involved in that decision. To diagnose it, so I think a CTPA. You could do a Q scan, but that's a bit difficult to organise in some places. So I think a CTPA with shielding is probably what ends up getting done, and that's reasonable. And then if there is one, a close discussion with obstetricians for thrombolysis.
The obstetricians will be led by you with thrombolysis. So what are you going to do?
I think it's probably safe. It's probably it's probably indicated here that right ventricular pressure upstroke doesn't look normal, and it's dilated. So I think she's got right ventricular failure and she's relatively hypotensive. So I think she's probably relatively safe, even at the thing that could be done as catheter interventionists on hand.
Okay. Obviously, these were things to consider, but the little proviso about thrombolysis is, what say once the baby suddenly comes in the next 5 minutes, and you've got a woman who's got a whole lot of thrombolytic agents. So I can tell you what happened, because it was quite an interesting little scenario, and it was the power of echo. We rang up the radiologist, and they said, well, what do you want to do a CTPA on this woman for? They said, it sounds to me like it's all pulmonary embolus, and if you give this woman a CTPA, her breasts are full of milk. She's at the peak time for glandular growth, and that if we do a CT scan, that will increase her risk of breast cancer at 20 years by such and such a %. So I thought, oh, well, was it worth it? Do I need that? So I went to the nuclear medicine people think, oh, we'll go that way. And we said, should we do a VQ scan? They said, yeah, we can do a VQ scan. Yeah, the mother's fine, it won't affect the breast. But by the way, the baby will get a lot of radiotherapy, radioactive material running through it. So the baby's almost, 38, 35 weeks. So you could do it, but we're not sure that we will be helping the patient. So then all these things which you run to, you forget they all have a price to pay. And I was very fortunate in having very erudite specialists I spoke to said, yeah, we can do it for you, but by the way, this is the cost or potential cost of the patient. So thrombolysis, what we decided, we'd put on heparin infusion on the assumption that she may throw off more emboli. We had the thrombolysis kept by the bedside in ICU so we could administer it at any time. And we had all the gear next to her. So should she go into labor or have a further pulmonary embolus, we would deal with it on the spot. And this is all in combination with the obstetricians. And then we monitored her for 2 weeks till 38 weeks. She wanted to deliver vaginally, and we thought that was a good idea. We agreed to that, the obstetricians and ourselves. But then they found she had large uterine fibroids, so she required a C-section. And after it was delivered, she went to warfarin, and they were an extremely grateful couple who brought the nursing staff a whole lot of presents. So, but it was interesting. It was just very interesting, and it was the power of echo because it was really all done on echocardiogram.
Can I ask a quick question? Did she have lower limb vascular Doppler ultrasound done that might provide supporting evidence for?
I'm sorry that you asked that question because when I was talking about it, I know we had it done and I can't remember what the reason was.
Yeah.
But yes, we would do that routinely. So, look, I'm just going to mention postpartum cardiomyopathy because everybody gets concerned about it. And this is, for example, the one on the left is 6 weeks postpartum. On the other hand, this is a woman that I've known for a lot longer who's had it 25 years ago and still has a considerable defect in her contraction, but lives a normal life, raised a family and enjoys life and doesn't really think about it apart from taking her Prindopril every day. Peripartum cardiomyopathy, it is rare. It is, it's a rare form of cardiac failure first described in Edinburgh, 1850s. You could say it's around about 1 to 5,000 births as a rough guide. And less than 1% of all cardiovascular events in pregnancy are peripartum cardiomyopathy, although it always gets the limelight. Remember, you've got to have defined criteria. And so it's the last month of pregnancy to 5 months postpartum. You do not have any other demonstrable etiology. And there's an absence of heart disease prior to 8 months pregnancy. And if you're going to use some criteria, an ejection fraction less than 45%, you'll find these definitions are quite rubbery with people. I use the term rather freely, which is unfortunate because it does carry quite an important treatment message. This is just when patients have it. You can see most of them, it's diagnosed on the day of delivery, but it can occur postpartum, and as you can see, 123 occur after the delivery in this group. I forget the exact number, but I think it was about 160. So the reality is you don't lose the risk after delivering the baby. If someone like that lady I showed you before at 6 weeks, she was sent to me because she was breathless and she had an ejection fraction of about 15%. I think it's my last case. Is that my time is up?
Your time is up. Okay.
It's my last little case. There's only 2 slides. Well, 1 slide, I think. 17-year-old with palpitations. Frequent, that should be SVT. I got to see her many years ago when I was doing cardiology practice. She had SVT, range radio frequency ablation, reasonable result. When she was pregnant in the 20s, she came back to see me. She was worried about her heart, and we got her through the pregnancy. There was a few little odd things happened, but nothing really to worry about. Got through the pregnancy, baby born, but really after that time was never 100%. And then a few years later, it was noticed that her ejection fraction dropped off. I don't know, is this going to play? There's the middle one, is that playing there?
Yeah.
The one on the left, that's a JPEG. That shows that she's got a dilated left ventricular diastolic diameter at the tips of the mitral leaflet is 62 millimeters. This is halfway down the left ventricle, and the next one is at the apex. And I suddenly realized that I hadn't picked it up. And this had been the problem all the way through. Can you take
Michelle?
Is it that compacted?
Nice, what do we call that? Non-compaction. Fantastic.
She had left ventricular non-compaction cardiomyopathy. And this is a very dangerous condition. And in fact, after that, because she had arrhythmia, she's got a defibrillator. And these people escape notice, and even though she had echo, we hadn't really picked it up because it is a diagnosis that really didn't come to the forefront until about 10 or 12 years ago, and then we went into sure it was real, but we know it's real now. And what you get is you get these big strands of muscle halfway down the ventricle into the apex. It doesn't show that well on the right, but that's just solid muscle at the apex. There's hardly any blood there at all. And what happens is these people are very prone to arrhythmias, very prone to sudden death. The left ventricular ejection fraction starts dropping off along the line, and when that drops, that becomes even more of a bad prognostic marker, and they often die in their 30s and 40s from sudden death, which is presumed arrhythmia. So just keep in mind, you got through the pregnancy, but I'm a little slow. The penny didn't drop for another few years after that. So I thought I'd just finish with that. There's lessons learned along the way, I think. Just messages, intensivist pregnancy and echo, keep an open mind, but always do an echo as soon as you possibly can.
Is that just in the pregnant people or in all patients?
Well, I'm talking about obstetrics and echo and intensivists. You know, someone like me would say everywhere, but for pregnancy, always do an echo. Do not take people's presumed diagnosis. You get the answer so quickly and you know what you're dealing with.
Amazing. Prof, thank you very, very much for a great talk. Are there any questions for Prof?
Thanks, Prof.
No, I think if there are no questions,
Good to see you.
well, if there are no questions for Prof, I'll say thank you very, very much indeed, and I'll stop the recording. We'll have a chat about some of the exam questions.